continue on with type 3. The reason I decided to take a break is I wanted there to be sort of a mental division between type 2 and type 3. Okay, so type 3 we're talking about after the break. Because type 3 involves antibodies and antigens, but it involves them in a different way than type 2. So with type 3, you've got what we call complexes that form. So the antibody and the antigen actually find each other, just like what we saw in type 2, but it's in circulation. The antigen isn't found on a plasma membrane. The antibody doesn't circulate through and bind to a tissue. The antibody finds the antigen in circulation, like in the bloodstream, and they bind and they form a complex. And then that complex actually gets stuck and lodged somewhere. Does that make sense? So they're uniquely different, and these are the two that students mix up the most, and that's why I wanted there to be kind of this mental bio break in between 2 and 3. That's why I made that kind of quick call. That, hey, this might be helpful for you guys to remember. So these immune complexes that form are in circulation. And so you can see in that top diagram, there's an antibody, and we draw this classic Y formation, right? We talked about this in the last lecture, but the Y formation, the antibody finds the antigen that's in circulation, which are these green spheres, and it forms this complex. And if this complex gets lodged or stuck in the vessel wall, it's going to form what we know as vasculitis. And you've got the circulating neutrophil that attacks it. You've got complement that's circulating the bloodstream that gets activated. And you have this hypersensitivity in the blood vessel wall. But the antigen and the antibody find each other in circulation. Well, there are some other tissues where this is highly at risk for happening. And these are other areas where blood is going to flow or be filtered, and you could get these complexes lodged in a tissue location. And so you can see that in a joint space, we would have arthritis, and this is what we call reactive arthritis. In the kidney, we would find this to be lodged and formed as glomerulonephritis, which was the question that was asked a little bit earlier in some of these patients. And we'll look at glomerulonephritis when we talk about kidney diseases, and we'll talk about acute onset of glomerulonephritis, where these little kids will get these infections, and that complex actually floats around and gets stuck in the kidney. So kidney disease, joint disease, reactive style of arthritis, and then vasculitis like we just talked about. Okay? Now, type 4. Type 4 is the only one of the group that has a T-cell response. It has a T-cell response that's dominant. In the 1, 2, and 3 types of hypersensitivity, there's no T-cell response. You only find it in type 4. It can be either CD8 or it can be CD4. It involves the phagocytic cells. You get tremendous destruction of tissue that's initiated through CD8 cytolysis. It's initiated also through lysosomal enzyme degradation. And if it has the recruitment of activated macrophages, which usually is the case, then you get the release of reactive oxygen species into that tissue bed. So we've got two main types. We've got delayed hypersensitivity right here that involves our CD4 and CD8. We've got our antigen-presenting cell presenting to our T helper cell. The T helper cell makes cytokines. We also see that the CD8 cell can make these cytokines. They recruit activated white blood cells that come to the area and target the tissue. And then we've got the specialized T-cell mediated cytolysis that happens through CD8 cytotoxic T cells. And those cytotoxic T cells can target tissue injury directly. So again, CD4 mediated across the top, CD8 mediated across the bottom. And CD8 is also involved in the top response too by recruiting macrophages, but their main claim to fame is their cytotoxic T lymphocyte activity, where they destroy via cytolysis the tissue that actually is expressing the antigen. So some classic examples of type 4. Crohn's disease. This is where the body's immune system attacks the GI tract. Contact dermatitis. This is a term for a skin reaction due to exposure to allergens or irritants that are on the skin, like poison ivy or poison oak. Multiple sclerosis. This is where your immune system, like the CD8 positive T cells, are going to attack the myelin on your myelinated nerves. Type 1 diabetes mellitus, we talked about that at the beginning. This is an autoimmune disease where you attack antigens on the beta islet cells in the pancreas that manufacture insulin. And so insulin production decreases over time. Now again, we'll talk more about type 1 and type 2 diabetes later in the semester, but in type 1 diabetes, it isn't that there is no insulin being produced typically. It's usually that the insulin levels are so low that they're not physiologically active. It's not initiating an ethyl response. Okay? And it's also something that can happen over time, slowly. So some of you know people that develop type 1 diabetes like when they were in their 20s. And what happened up until they were 22? I thought it was child onset diabetes. That was the old thing that we used to call it. We used to call it child onset for type 1 and then adult onset for type 2. And that's no longer the case. Kids have type 2 now, and adults seem to have type 1, right? All the rules are changing. I wish I could blame it on social media, but it has nothing to do with social media. So in type 1 diabetes, no longer called child onset, if the beta islet cells are manufacturing, say, 70% of the insulin that they normally should, and your body is slowly attacking it, and then it drops down to 60% by the time you're 15, and then it drops down to 50% by the time you're 19, and then by 22 it's down to about 35% of the insulin. That may not be enough now to maintain normal glucose levels, and that's when the patient starts to become symptomatic. Okay? So these are things that can happen quickly. These are also things that can happen slowly over time in the case of type 1 diabetes. Okay? Same thing with like Crohn's. Some patients develop Crohn's later in life. Like, what happened? Why was the GI tract fine before that? Well, it was a slow attack over time that took place. And then it crossed over a threshold and it became symptomatic. Okay? Last one, Hashimoto's, and we'll take your question. So Hashimoto's disease is when the T cells themselves destroy the thyroid. And we'll talk more about this in the endocrine lecture. But all of these are type 4 hypersensitivities. Okay, question?
In the previous slide, you said what is the top of
This slide?
Yes.
So the top panel
Yes.
is looking at CD4 or helper T cell involvement in triggering activated macrophage recruitment. Now, cytotoxic T cells or CD8 T cells are also involved in that peripherally, so that's why they both show up on that slide. The bottom slide is CD8 cytolysis all by itself. So both of these are in play. Both of these pathways are happening with type 4 hypersensitivity.
So both of those scenarios are both delayed?
Yeah, I would agree with that statement. I mean, delayed hypersensitivity is really what type 4 is. It doesn't happen as delayed in the sense like in contrast to like an allergy response. Like you walk into a house if you're allergic to cats. I mean, usually people that are allergic to cats know that there's a cat in the room like within minutes of arriving. And with type 4, it's considered delayed hypersensitivity because, like for the case of diabetes mellitus type 1, it could be years before it manifests. So it's just a slower process, and that's why they call it delayed. Okay, let's talk about transplant rejection. So in transplant rejection, this is a type 4 hypersensitivity, transplant rejection. We've got two pathways that are in play. We've got a direct pathway, which is down the middle. We have an indirect pathway, which is down the right. And in these situations, we've got an incompatibility of graft versus host. And the incompatibility mismatch is due to major histocompatibility complexes. And so that is the antigen, the name tag that tells the cells in your body who that tissue or that cell belongs to. And so if that MHC complex doesn't match you, it's considered non-self, and it's going to trigger an antigen response towards it. Okay? So that's what's happening in a transplant situation. Now there are possibilities where you can do a match. You can find a donor that has similar MHC complexes. It's very, very laborious to find those matches. You used to hear about that a lot more 10, 20, 30 years ago when we were doing a lot more bone marrow transplants from one patient to another. They still happen, they're just not as rampant. And the other thing is the immunosuppressant drugs are more sophisticated today than they were decades ago. And so we don't worry about it as much today as we did back then. Okay, we're going to talk about immunosuppression here in a second. That's where this is going. So if you look at these two pathways on tissue rejection, we've got a direct pathway here where you've got the antigen-presenting cell in the graft itself. So the tissue that was donated has an antigen-presenting cell in it, and it's showing MHC class mismatch. That triggers CD4 helper T cells to initiate activated macrophages, as well as turning on antibody production. And it also triggers cytotoxic T lymphocytes to come and attack the tissue that's being transplanted. In this case, it's a renal tubule. We're talking about a transplanted kidney. On the right, or the indirect pathway, here we've got the graft cells that have antigens on them. Those are those yellow bumps. And in the recipient, in the host, you have an antigen-presenting cell that sees that, and it shows it to a helper T cell, and the helper T cell triggers the reaction to make antibodies to destroy the donor tissue. Okay? So how can you prevent this from taking place? Well, one of the easiest ways to do this is with immunosuppressant drugs. And so one of the more widely described immunosuppressant, it's not the only one, but it's been around for a little while and it's actually pretty successful, is cyclosporin. And the way cyclosporin works is by blocking co-stimulation. So if you think back to the last lecture, when we talked about co-stimulation, and we talked about how if you're going to trigger an attack on a piece of tissue, right, you want to make sure you don't just have one signal. You want to have this confirmation signal that says, yeah, this is what I want to do. I actually meant to hit the nuclear warhead button, right? And so co-stimulation is, the first signal isn't enough to trigger the attack. You need a secondary co-stimulatory signal to actually make it happen. And that's where interleukin-2 play a role in this mechanistic pathway. So you remember this is a lymph node, and you've got the CD8 side of the equation on this side. We've blown this up in higher magnification. You have the antigen presenting cell presenting the antigen to a naive T cell. Now the naive T cell becomes activated by a co-stimulatory event of interleukin-2 being released and binding to itself. And now you make effector T cells that go and attack, and you make memory T cells that remember the next time the antigen shows up to act quickly. And cyclosporin blocks that release of interleukin-2, so you never get that activation. Okay, and that's how you can avoid transplant rejection. But if we have transplant rejection, what does it look like? So in the theme of kidney, since we're looking at the renal tubules, this is a kidney transplant. Didn't go well. Okay? This is a rejection in the hyperacute and acute graft rejection phase in panel A. So this is a kidney glomerulus. You can already see that the Bowman space, this white space that's here, right here, it's compromised. See this white space up top? This should continue all the way around as Bowman space as part of Bowman's capsule. And you're already seeing the formation of tissue infiltrate and cellular infiltrate into that Bowman space. In panel B, the next one over, we're starting to see that there's an acute cellular rejection of the kidney. We get inflammatory cells that are migrating into that tissue bed. And you see higher population of these inflammatory cells that are the purple dots that are more prevalent than the picture on the lower left. So more purple dots, more inflammatory cells here, fewer purple dots, not as many inflammatory cells there. We move over to panel C. In panel C, now we've got humoral rejection. The blood vessels are starting to respond. So you're looking at scarring in the form of vasculitis, where we've got, do you see this structure right here? This is the wall of the blood vessel that's starting to scar. Over here, this is a cross-section of a blood vessel in the kidney. This is the lumen of that blood vessel, and all of this stuff that's in the lumen, this white space should have filled this whole inner circle. And all of this is that vasculitis response that we're seeing as we're getting things kind of building up on the inside lumen of the blood vessel. Okay, type 4 type of rejection. So here we've got antibodies, complement activation, leukocyte recruitment. We're targeting tissue through CD8 pathways, and we're recruiting inflammatory mediators through CD4 pathways, and we basically get thrombosis of the vascular system in the kidney, as well as the destruction of kidney cells along the way. Okay. Let's talk about autoimmune diseases. They're a form of hypersensitivity. A lot of these autoimmune diseases, we looked at like diabetes mellitus is an autoimmune disorder. Multiple sclerosis, it's an autoimmune disorder. So what's going on? It's kind of to the question that was asked earlier, right? Why is this happening is another way to phrase your question, right? Like what's the evolutionary significance? I don't know the answer to that, but we do know the answer as to why it's happening, how it happens, what went wrong. And what went wrong is we're actually having the breakdown of these self-tolerance mechanisms. So if you think back to the last lecture, we talked about, or the virtual me talked about, right? We talked about when you make B cells and you make T cells, you go through all this energy to manufacture unique combinations that are going to be able to anticipate what might be exposed to. And as you go through the iterations, the different combinations, you inevitably come up with combinations that bind and are self-destructive. And then you eliminate those, if everything goes well. You guys remember that? And you eliminate them through 2 different pathways. And do you guys remember what those pathways are called? What was that? I heard it. Central tolerance and then peripheral tolerance, right? So in central and peripheral tolerance, you identify those B and T cells that are self-reactive and you get rid of them, right? Like we said, more than 90% of the combinations that you generate of B and T cells are self-reactive. And then you actually say, let's start over, okay? What happens if one of those self-reactive B or T cells gets out? That's when you have an autoimmune disease. So that's how it happens, right? You've got the breakdown of these self-tolerance mechanisms. And a T cell, for example, that shouldn't have been released into the wild because it was poorly behaved, right, gets out there and it causes problems. And that is how autoimmunity happens. Now, what's the benefit to the earlier question? I have no idea, okay? I can just explain to you that this is the leak within the process of how they show up. So it's not surprising that they do occur, right? It's actually surprising it doesn't occur more often, in my opinion, because the number of iterations or copies or trials that we make of B and T cells to try to anticipate all the different things that we're going to come across are pretty vast. And the fact that it works pretty smoothly most of the time is relatively impressive. But most of us have some sort of allergy, case in point, right? Most of us are allergic to something, right? Somebody's like, I don't know what you can do. Well, you know, you probably haven't seen every antigen, okay? Some people move or come visit an area to only discover that they are allergic to some plant in that particular area, right? And then here's usually what happens is somebody gets a job in an area, they go visit, and they're like, oh, there must be something here that's bugging me. And then they move away, or they go back home, and they get the job offer, they pack up their house, and they move to that area. What do you think's going to happen when they move there? It's going to get worse, right? Because that's the second exposure, right? That's kind of like the evil company recruiting. So I advocate, if you're relocating to an area for a new job, in your reload package, you should negotiate an allergy test in that new area. Find out what you're allergic to. Okay, that was free career advice. All right, so in the pathogenesis of autoimmunity, there are triggers. There are triggers that could be genetics, which is what we're talking about, but there's also potential for environmental triggers. So let's look at some of these things that could have a genetic component as well as an environmental component. So we look at systemic lupus erythematosus, or SLE. So there is a box up at the top middle of the slide that says inherited susceptibility genes. So this is the genetic component. And then there's a box in the upper right that talks about environmental triggers, like, for example, light or UV radiation. So patients that wrestle with lupus, usually it's exaggerated, their symptoms are exaggerated when they're exposed to light. And there's a lot of kinds of diseases that are very light sensitive. And so light tends to be one of the most common, or UV radiation tends to be one of the most common environmental triggers in a lot of these autoimmune disorders, okay, or the lack of light in some cases. And so here you've got these genetics as well as environmental kind of converging on these self-antigens. So they both will influence the way these self-antigens behave. And those self-antigens will move on to trigger the activation of helper T cells, the CD4 positive cells, as well as B cells, and produce autoantigen production, or autoantibody production, and they stimulate cell destruction as things take place. So in the case of SLE, it's a type 3 hypersensitivity. Okay, systemic lupus erythematosus is a type 3 hypersensitivity. There's other types. There's like up to 4 described types of lupus, and systemic lupus is the most aggressive. But there's one that's skin only. There's one that's fetal. It only happens in the infant or in the fetus. There's one that's drug-induced, and then we've got systemic. So skin, fetal, drug-induced, and systemic. Women outnumber men in this disease. It's a very sexist disease, right? So 9 to 1. 9 women to every 1 male has systemic lupus. There's 1 case in about 2,500 in the population, and UV light tends to exaggerate the problem. So what are the symptoms or the clinical significance? Well, we've got necrotizing vasculitis, which seems horrible, right? So this is a vasculitis in the blood vessel. That's that disease complex that forms, or this is a type 3. So the antigen-antibody complex forms. It floats, it gets stuck in the wall of the blood vessel. It triggers an inflammatory reaction there, and that goes necrotic. So now you have blood vessel walls that are going necrotic. That seems bad. That is bad. Okay? Joint swelling, because the joints are the ones that get some of these complexes, and these complexes stick in the joint, and now they actually have joint problems. Not just the large joints, it's not just knees, shoulders, and hips. It's like the fingers, all of these synovial joints that happen all over the body, and the feet, and the hands, the wrists, and the ankles. You've got skin erythema, that's reddening of the skin. So reddening of the skin because you've got a reaction that's taking place at the level of the skin. There could be a CNS involvement, a central nervous system involvement. that usually is due to the vasculitis that takes place in the small diameter vasculature that affects the neurovasculature that goes to the brain. And then the last one, but not least, is kidney disease. So this is a picture of a little girl, and 9 to 1, more prevalent in females than in males. And you can see over the bridge of the nose this butterfly rash. This is a very common, and it usually goes between red and like a dark brown. And it kind of goes over the bridge of the nose and then flares out kind of over the eyes and then under the eyes and looks kind of like a butterfly marking. And it's a very common symptom of the skin erythema that's happening, or the red skin that's happening because of the skin being irritated with this reaction, this type 3 hypersensitivity reaction. And so when it flares up, it's red, and when it kind of calms down, it's usually like a brown scarring color. Okay. What about rheumatoid arthritis? Not reactive. Reactive was a type 3. Rheumatoid arthritis is a type 4. Rheumatoid arthritis is a type 4. So this is different than osteoarthritis. You're like, oh man, how many arthritises are there, right? So those are the main ones. Reactive is type 3. Okay. Rheumatoid is type 4. And osteo is just old people arthritis. Okay, what? That's just bone on bone, where you've worn out the cartilage or the meniscal tissue and you're getting physical mechanical abrasion. But in, what's that?
What's it called, the last one?
Last one, which way I went? Reactive, rheumatoid, and osteoarthritis. So the cause, there seems to be some erythrogenic agent that triggers this. The studies suggest that it may be type 2 collagen. So your body, as a type 4 hypersensitivity, the antigen that your body sees is type 2 collagen. That's actually pretty prevalent in a lot of places in the body. Okay? But it's highly prevalent in these joints. And so with the antigen, you actually trigger the CD4 positive T cells to be activated against the type 2 collagen. And as they become activated, you can see the different pathways that ensue. And you've got autoantibodies due to B cell activation. You've got macrophages that get recruited. You activate the endothelial cells in the area. And all of this destroys the bone, destroys the cartilage that's in the area. It causes what we call a pannus ingrowth. I'll show you that next. And it leads to ankylosis. So the pannus that's shown here, this is a massive synovium and synovial stroma tissue that has rampant inflammatory cells present within it. It has granulation tissue, fibroblasts would grow over the articular joint cartilage and cause problems, and it eventually bridges the opposing bone and causes a bending of the joint. And the bending of the joint, or a stiff and bent joint, is the word ankylosis. In the Greek, it actually means crooked. Okay, so patients that wrestle with rheumatoid arthritis are the ones that usually affects the small joints first. And so in the hands, it's where their hands get kind of like, as they kind of curve one direction or the other. And usually it's bilateral. Whereas osteoarthritis can be unilateral. So like a former professional baseball pitcher could have osteoarthritis in their throwing arm, but the other arm is fine. Rheumatoid arthritis is bilateral. So if you have an older patient that's wrestled with it for a long time, then a long time you have this pannus ingrowth, and that's when the fingers start curving. You kind of seen pictures of the ankylosis in rheumatoid arthritis. It looks pretty gnarly. It looks painful. It is painful from what I understand. Okay. You've got synovial destruction on this left picture. You can see a quote-unquote normal joint on the left. You can kind of appreciate where the synovial membrane is. You can see the cartilage, right? The articular cartilage. And then over on the right side of this slide is where we've got this rheumatoid arthritic problem that's taking place. This is all of the ingrowth of the pannus, And as this spans between bone to bone, it causes this joint to bend. And the bending of the joint we're going to see here on the next slide. But the middle slide that you see, this is a magnification of the synovium, where you've got hypertrophy and you've got dense lymphoid aggregates that are seen. That's what all of that purple dot cellular infiltrate are lymphatic tissues that have moved in. Lymphatic cells, rather, that have moved in. Type 4 hypersensitivity, rheumatoid arthritis. On the far right, this is the lymphoid aggregates in higher magnification. You can see the red arrow. The red arrow is pointing to these aggregates right here. As all of these cells, these lymphoid cells start to fuse, they start forming these aggregates of tissue over time. So, organs that are affected in rheumatoid, we've got joints, skin, blood vessels, heart. We've got lungs, as well as muscles. So rheumatoid arthritis is not just at the level of the joints, because you have type 2 collagen in all of those tissues. Right? That's the atherogenic agent. That's the antigen that you seem to be harboring a response to. The ankylosis is the bending. It tends to be episodic, meaning that there are times where it's more problematic or aggressive than others. Usually during times where it's damp and there's a lot of moisture in the air. Small joints first, we talked about that. It's symmetric, so it does both sides of the body, in contrast to osteoarthritis. And this arthritic factor has been identified in as many as 80% of the cases. So what's the other 20%? I don't know. They didn't find it. Is it because it's not there, or it was just undetectable? I don't know the answer. Or is it only collagen type 2? Probably not. Maybe it's another type of collagen, but that's in a lower percentage. Okay? Question?
So the collagen just keeps accumulating in the joint?
No, that's not collagen that's accumulating. The collagen that's in the joint is the atherogenic agent, and it has the antigen, so you make antibodies against it. And as you bind the antibody to the type 2 collagen, you recruit macrophages. They release growth factors and cytokines that stimulate tissue ingrowth, and you get an inflammatory reaction within the space. The amount of collagen 2 doesn't change. It's the collagen 2 that's the antigen agent that triggers the cascade of events. But that collagen 2 is found in heart muscle. It's found in blood vessels. It's found in the skin. And that's why these other organs are also affected. So the patients wrestle with these aches and pains all over the body. It's not just in the hands and feet. Okay? Type 4 hypersensitivity, yeah.
Why would it being like damp outside affect?
Why would being damp outside affect?
Yeah.
So like in high humidity environments, you get a lot more tissue swelling if there's inflammation. And because there's an underlying inflammatory disease, it tends to aggravate it more. Because there's more moisture in the air, and so if you have tissue that's swollen, some of that fluid will dissipate into low humidities, but if the humidity is high, you won't get fluid exchange. Why? You sound like my kids at home when they were younger. Why, Dad? Why? Finally, I get to the point like, I don't know. Go ask your mom. She's smarter than me. Okay, and you can see on this picture kind of the images that that are being shown here. We've got two different pictures that you can kind of take a peek at. So this picture is earlier in the process, but you can actually see there's a blow up here of this particular. Let's see, where is it? Which one is it? Yeah, it's right here because you can see this little defect right here that's blown up. So over time, in this particular patient, this is going to like eat away at the bone. And then over here, we can kind of see in this particular patient, there are two different images, two different folks. you've got these areas of inflammation, and that's what's lighting up. So there's a lot of fluid, back to your question. And so under X-ray, under a radiograph, the bone's gonna light up white as well as fluid. And so you have a lot of fluid in this particular area at these levels of these joints. It's not supposed to be there. That's because of the high inflammation that's present. Okay, the last slide, and then we'll take a short break, and then we'll come back to finish up, okay? But the last slide for here is this table. This came from a different textbook, and I just wanted to share it with you because it's not found in your textbook. And depending upon which audience or textbook that you read, you're going to get kind of slightly different variations of classification, where we're teaching about 4 different types of hypersensitivity. That's a pretty well accepted nomenclature, is 4 different types of hypersensitivity. But this chart actually helps to characterize some of the features and is a great study tool. So you got type 1, type 2, type 3, and type 4. You can see antibody, IgE, antibody, IgG, IgM, antibody, IgG, IgM, and then here, none, because it involves T cells, right? And so it gives you some information about the 4 different types of hypersensitivity, okay? Search animal, for sure. All right, any questions?
So is type 4, can it be, rheumatoid arthritis, can it be induced by drugs like alcohol and, I don't know, other types of drugs?
Rheumatoid could be induced by drug. Not that I know of, but I'd have to look into it a little bit. What's interesting is, I haven't heard that about rheumatoid, but what I've had read a little bit about, and it's more of a theory at this point, is MS, multiple sclerosis. So there are certain like recreational drugs in dangerous frequencies that have been associated to correlate with higher risk rates of developing MS. But I haven't seen that with rheumatoid arthritis. Okay. So yeah, so you don't necessarily increase your risk of rheumatoid arthritis, I guess, if you do a lot of drugs, but maybe MS, if that's good news to you.
Why is type 2 called cytotoxic, like on the last slide?
Oh.
Aren't there some cytotoxic activities going on in type 3 and type 4?
So where are we? Type 2. Oh, so again, this came from a different textbook, so like some of the nomenclature is different. So in there, type 2 cytotoxic, that really gets its name from the blood transfusion history. So if you deliver one type of blood to another patient, the reaction that will happen is you'll kill the erythrocyte. You'll literally destroy it. So, and then like anaphylactic, like not everybody goes into anaphylactic shock if they're allergic to dandelions. But there are classic examples of anaphylactic shock with bee stings, penicillin allergies, shellfish, peanut, right? Okay, let's take another quick break. There's a lot of material today, so I want to give you as many breaks as possible. And we'll come back and we'll finish up.